Yeah, so thank you for the introduction. So yeah, I'm Yasmin. I'm a dietitian at the Royal Free Hospital, and I work or specialize in neuroendocrine neoplasms. So thank you so much for having me, and thank you so much for so many people joining this late on a Wednesday. So it's lovely to be here. This talk, I'm going to cover two main topics in this talk. Firstly, the importance of good nutrition, and I'll make mention to exercise. So I'm not an exercise therapist or a physiotherapist, but I will just make mention to exercise as well. But really around the importance of maintaining good nutritional status and what that means. And then I'll also talk about symptom management. Obviously, that does vary depending on what symptoms one's facing, where you are in your patient journey, the underlying diagnosis or condition or any other underlying conditions, previous treatments and surgeries and that you may have had in the past, and what current treatments you're undergoing. All that can impact on the symptom management or symptoms that you're experiencing. So I think it's just being aware of all those other sort of factors that may interplay as well. One just caveat with this talk is that there are a number of factors that impact on dietary requirements. And if you're unsure, then it's important to reach out and ideally speak to a dietitian if possible. So firstly, starting to talk a little bit about maintaining good nutrition. So when we talk about the term malnutrition and what it actually is, so the WHO defines malnutrition as deficiencies, excess, or imbalances in intake. And in the clinical setting, we often are talking more about sort of deficiencies. Malnutrition is caused by having an inadequate diet or inadequate diet intake or problem absorbing nutrients from food. So it's either not getting enough in through eating or it may be from an absorption issue. To measure malnutrition, we might use measures of weight loss. And I think it's really important to note weight loss because I have had patients that have come to clinic and said, look, my GP said I'm a healthy BMI or overweight or even obese category, but I've lost a lot of weight. I didn't mean to lose this weight. And that's really important. And actually they are still at risk or may already have malnutrition. Body mass index may be a measure that we use to support assessing if someone's at risk of malnutrition. And that's a ratio between weight and height. And there's some, main categories are there at the top of the screen there. But it is quite a crude measure and it doesn't measure or doesn't take into account muscle mass. So we may also look at sarcopenia. And we're learning more and more around sarcopenia in the context of cancer, but also now we're learning more around with neuroendocrine neoplasms specifically as well. So sarcopenia is defined as a musculoskeletal disease where muscle mass, strength, and performance are compromised. And it's generally associated with aging, but we can see it with certain conditions, including cancer. It impacts on ability to perform daily tasks and maintain independence, which obviously will impact on how somebody is running their life for their day-to-day activities. It can contribute to frailty and increased risk of falls. And we're now getting more information that actually it can contribute to how well somebody does with treatments as well. Sarcopenia is treated with nutrition and exercise, and they go hand in hand. And I have at the top of the two pictures up there. So one is a CT scan. So sarcopenia can be assessed by a trained physician to assess using an MRI scan or a CT scan, or we can use some functional measures to support a diagnosis of sarcopenia, and that's a grip strength we have up there as an example. So if anyone in this room is saying, well, I'm well nourished, I'm not losing any weight, and I've not got any particular symptoms, but what should I be eating? Well, we still advise to follow the general healthy eating advice. So, and this is in line with the Eat Well guide. So aiming for plenty of fruits and vegetables per day, so at least 5 portions of fruit and vegetables per day, and trying to eat a variety of these. Getting plenty of whole grain carbohydrates in the diet, eating less red and processed meat, and the less red processed meat in particular, the better. I always include this when I talk to my patients, even though it's not really specified in the Eat Well guide, but including good sources of protein in the diet is really important. And that is just because if there is any underlying muscle loss happening, protein is really important. So trying to get protein in with each of your meals, for example, including yogurt or eggs with your breakfast and, protein source with your lunch and your evening meal. Going for low-fat dairy products or plant-based alternatives if you're following a vegan or plant-based diet, but ones that are fortified with calcium at least. including healthy fats from nuts, seeds, vegetable oils in the diet, but generally overall reducing our fat and sugar intake as well is in line with healthy eating. Ensuring we're keeping well hydrated. So men are recommended to drink 2,000 milliliters of drinks as water a day, and women 1,600 milliliters as water a day. But that might be, diluted fruit squash, for example, as well. That can include, but that's it. That's mainly sort of drinks that we should be aiming for. And then obviously including as much physical activity as we're able to do to keep ourselves fit. If anyone on this call is struggling to eat or maintain your weight, then the advice sort of shifts. So really, I would encourage you to seek support where needed, and you may be referred to a dietitian for further support. Eating little and often, so having regular meals and snacks can be helpful, especially if you've not got a great appetite and a large meal is overfacing. Trying to optimize on your energy intake and your protein intake. So going for more high energy, high protein foods and drinks. So rather than the low fat dairy, going for the high fat products, for example. Food fortification is a term where we talk about adding in extra calories from fats, sugar, and protein into the diet. So, for example, adding extra butter, oil, cream into foods. I've got a picture down there of dried skim milk powder. So you can add 1 to 2 tablespoons of skim milk powder into half a pint of milk, and that will actually increase the protein content of the milk, and that can then be used for drinks, cereals, anything you might use milk in throughout the day, as long as you tolerate milk, okay, that is. So it's about sort of making every mouthful count as far as calories and protein. It's important to consider what the barriers are maybe to eating and potentially drinking, and talk that through with your health professional. A question that I get quite a lot is if you have diabetes, what do you prioritize? Well, actually, if you're losing weight, you fit into that category of needing nutrition support. So we should still be prioritizing the high energy, the high protein diet. And actually, sort of fortunately, fat and protein actually reduce how quickly our body deals with sugars in the diet. So, for example, if you had a full sugar jelly, your body will digest you will digest that sugar quite quickly and absorb that sugar quite quickly. But if you add some cream to that full sugar jelly, you'll actually digest it slower, and it will lead to a slower, more sustained rise in the blood sugar levels. So that kind of does work to our advantage where we do have patients who have diabetes but are losing or struggling with their weight. And regular meals and snacks is again really important if one has diabetes as well, especially with type 3C diabetes, where it can impact on not only insulin levels but also glucagon levels. So you do less well in a sort of fasted state. And if anyone's on sort of twice daily insulin regimens or any medications that lower the blood that could cause hypoglycemia by lowering the blood glucose levels, such as gliclazide, then regular meals and snacks is really important, and that bedtime snack is recommended as well. So trying to have a snack within about an hour of going to bed as well that contains some carbohydrate to keep you through the night and prevent hypos overnight. So we'll talk a little bit also about vitamin and mineral deficiencies, because they fit into the idea of the issue of malnutrition and malabsorption. So where there is malabsorption, testing and supplementation may be indicated. And again, you can discuss that with your medical team. We don't routinely recommend high-dose supplementation where there's no deficiency. For example, fat-soluble vitamins are stored in the liver, and so there's a risk of toxicity. So we don't want you to be overdosing on vitamin minerals unless there's a confirmed deficiency and you need a high-dose supplement. Vitamin C as well, most of it comes out through our urine, and there's actually an increased risk of kidney stones if you're having high-dose supplements of vitamin C. So again, we don't really recommend high-dose supplementation. But a bog standard general multivitamin and mineral supplement is okay in most situations, and actually there's certain situations where we might recommend it as well, just because you might have higher requirements because there is some malabsorption happening. So we do recommend just topping up on those levels just to prevent deficiencies. So I'll talk a little bit about some specific vitamins and minerals that we see more, maybe pertain a little bit more specifically to neuroendocrine neoplasms, but just in the interest of time, I might not go into terribly too much detail about why the deficiencies happen, but just a little, I might brush on them a little bit. And it's also important to note that it's not an exhaustive list as well. So there are other things that we can be testing for, we might need to be considering as well. But if anyone on this call is suffering with carcinoid syndrome, where there is increased serotonin production because of the nets, then we recommend actually prophylactically starting a niacin supplement in the form of nicotinamide. And the guidance that we're following is between 75 and 100 milligrams of nicotinamide a day. And this is just because we're not producing enough niacin in the body, because all our amino acid tryptophan is being used up to produce serotonin. So therefore, there's a risk of this niacin deficiency. And as I said, I can talk about that a little bit more in the Q&A session if needed. We're not seeing deficiency symptoms actually so much anymore, and I think that's because we are being more proactive in supplementation if anyone presents with niacin, anyone presents with carcinoid syndrome. Folic acid symptoms are mainly around sort of anemia type symptoms, and because folic acid is absorbed at the sort of middle section of the small bowel, and certain medications, particularly bile acid sequestrants, can impact on absorption, then we see folic acid deficiency in these situations. If we are testing for folic acid deficiency or folate deficiency, which is another term, we should also be checking for vitamin B12 deficiency, because hydro supplements of folate could mask vitamin B12 deficiencies. So you really should be testing both, and ideally, if possible, zinc as well. And just some food sources of folic acid: liver, green leafy vegetables, and other vegetables such as asparagus and Brussels sprouts are good sources if you want to try and up your dietary intake. Vitamin B12. So again, there's a sort of a complex mixture of needing the stomach to absorb vitamin B12 and the end of our small bowel or the terminal ileum to absorb. So if you had any surgery or there's any disease impacting any of those areas, or you're on high dose antacid medication or proton pump inhibitors, there's a risk of deficiency, and so we should be testing. And it's quite an easy test to do, actually, and GPs can do it. And you may require supplementation, either oral, or if there's a real issue of absorption, you might actually need intramuscular injections every few months. And again, symptoms are very much around sort of anemia type symptoms. It's also kind of impact on memory as well. Main sources in the diet are meat, eggs, so mainly your animal protein sources, as well as fortified cereals. So if there's anyone on this call that's also following like a vegan diet or a plant-based diet, again, there is a risk of deficiency. You might need to just top up with an oral over-the-counter supplement, which you can get in supermarkets or chemists. And then I'm going to move on to fat-soluble vitamins. So these are mainly the case where patients are malabsorbing fat. So you're not absorbing fat, maybe due to surgeries in particular, or certain medications. And I'll talk a little bit more to that later on in the presentation. So vitamin A deficiency can result in night blindness condition, in worst case scenario. Good sources of vitamin A are liver, fish oils, vegetables containing carotene, so your orange vegetables like squash and carrots, especially when they're cooked, and if they're served with a bit of fat for absorption. But if you want a bile acid sequestrant, which I'll talk about a bit more later on, or have fat malabsorption, again, we should be testing and seeing whether we need a higher dose supplement. Vitamin K and E are other fat-soluble vitamins. Deficiency of both these is actually quite rare. With vitamin K, it's mainly bleeding disorders, and good sources in the diet are green leafy vegetables, beef liver, but also in our bowel, the bacteria in our bowel produces vitamin K as well. So I think that's why deficiencies are fairly rare, but we do see it in clinic. And so you may need supplementation, again, if there's fat malabsorption or being on bile acid sequestrants. Vitamin E, main sources are vegetable oils, oil-based spreads, egg yolks, nuts, seeds, whole grain cereals, and some fatty fish. And then vitamin D actually is quite a common deficiency in the UK and most sort of countries in the far northern hemisphere as well, and that's mainly because of our sun exposure. So vitamin D is really important for bone. It also plays a role in the immune system and can impact on mood, and so it can be has been linked to depression, as well as forming muscle as well. So when we talk about sarcopenia, vitamin D, that's really important. But the main source of vitamin D is from sun exposure, in particular UVB rays, which is impacted by cloud cover and pollution and the time of year. So the Department of Health in the UK recommends that actually for the general population, we do over the winter months, most people should be considering a low dose vitamin D supplement. And for some people who get less sun exposure throughout the year. Vitamin D is mainly found in oily fish and fortified cereals and fat spreads. But as I mentioned, we do see more deficiencies among our patients in clinic. And so, again, it's quite a fairly standard test that can be carried out in the community as well. And then we might need to supplement, but there's no harm in supplementing with a low dose supplement of vitamin D as per sort of general guidance for anyone. I'll just make a special mention to zinc as well. So zinc's a funny when it comes to diarrhea, which some of you may be struggling with. So zinc deficiency actually causes diarrhea, and diarrhea can cause zinc deficiency. So if you get diarrhea, you can get into the cycle where you actually then result in zinc deficiency, and that worsens the diarrhea. Also, surgery to the small bowel can impact on absorption of zinc again, so we may need supplementation in that case. Zinc is important for the immune system and the gastrointestinal tract and skin. Good sources in the diet are meat, legumes, eggs, fish, and grains. But with legumes and grains, to ensure good absorption, soaking or milling will help absorption of the zinc. Otherwise, it's not absorbed as well. So soaking your lentils, your pulses overnight will help before cooking. All right, so I'm going to move on to management of symptoms and to complications. So a lot of the section, will focus on bowels, and apologies if anyone's not, this isn't, relevant to anyone, but I think it's probably the major issue that comes up in clinic. So just firstly to say, bowel habits do vary between individuals. Anything from passing stools 3 times per day to bowels opening 3 times a week is considered, and maybe you can't see me, but inverted commas, normal. But it's also important to know what your sort of normal is as well. Diarrhea is defined as passing looser, watery, or more frequent stools than is normal for you. And constipation is defined as changes to how you poo, or including not going as often or finding it harder to go to the toilet, as well as passing dry, hard, or lumpy stools. So if we talk about diarrhea in particular, I find in clinic it's a major complaint, and it really does impact a lot of patients' quality of life because they always need to know where the toilet is. And there's a number of causes potentially with diarrhea. So that includes surgery, so anywhere, any abdominal surgery, whether it be the GI, the gastrointestinal tract, or even gynecological surgery. Small intestinal bacterial overgrowth, which I'll talk a little bit more about. Issues with the bacteria in the bowel as well, so like dysbiosis, so an imbalance between the beneficial bacteria or the good bacteria in inverted commas versus the sort of less beneficial bacteria, the bad bacteria. Conditions called bile acid malabsorption or bile acid diarrhea, which I'll talk about a bit more as well. Deficiencies, and I mentioned zinc as an example. A condition called pancreatic exocrine insufficiency, which you may have heard of, and I'll talk about a bit more as well. Irritable bowel syndrome, which is really a sort of a sensitivity or an overreaction between what's happening between our brain and our gut. And there is a link between what goes on in our brain and our gut. There's a relationship, and we know that. So for some people that is sort of exacerbated, and that results in irritable bowel syndrome type symptoms, whether that be diarrhea or constipation. But I'm conscious some patients may have been actually diagnosed with IBS before they had the diagnosis, which is obviously probably a not good part of your journey. So yeah, so I won't probably touch much on that, but it's just to mention, if anyone's got functional NET or syndromes, such as carcinoid syndrome, for example, which can then in itself cause diarrhea. Some of the treatments, so somatostatin analogs, for example, or if anyone's had any radiotherapy to the gut, or anyone in the abdomen, that can cause diarrhea. Infection, intolerances to certain things such as gluten intolerance and celiac disease or lactose intolerance. Just on that though, I would encourage anyone who thinks they need to cut out foods out of their diet that they do have a conversation with the dietitian, because it's easy to get into a bit of a spiral, cutting out foods and keep cutting out foods and not getting anywhere, and then just getting to a point where you're having a very unvaried diet and risk deficiencies or malabsorption. So that really does need to be with support. Or inflammatory bowel disease such as ulcerative colitis or Crohn's. And there may have been interplay between these issues. So we may have to look at look at each issue and sort of tackle each one by one as well if there is a few things going on. So if anyone is suffering with diarrhea, then it's important that we consider the causes of the diarrhea. And so that's a conversation to have with your team. And they'll probably be asking a bit more detail around the diarrhea. So what color is it? Is it that kind of pale yellow, floaty, oily stools that we see with steatorrhea and some of the conditions I'm going to mention a bit later on? Or not so much. It's more like a watery diarrhea, maybe more due to sort of functional nets, for example. When we look at the Bristol stool chart, and that can be a useful tool to identify sort of what your stools are looking like, and it may vary as well. And that's important to say. Actually, my stools vary in amount, frequency, color, and type. Generally, type 4 is what we consider normal. Anything above that is more towards the constipation. Anything below that is more towards the diarrhea. So talking about some of the specific conditions which can impact on the bowels. So pancreatic exocrine insufficiency. So main risk factors for this are somatostatin analogs can cause pancreatic exocrine insufficiency for some patients, or surgery to the pancreas. There are other conditions, but they're not sort of specific to NET, so I won't really touch on those. Symptoms really include these foul, frothy, smelling, frequent, pale, floating, oily bowel motions. These symptoms are what we call steatorrhea. Abdominal pain, abdominal cramping, flatulence can also be symptoms, and unexplained weight loss as well. And steatorrhea, so those fatty bowel motions, or the pale motions, that's actually quite a late effect. So if someone is saying, oh, I think you might have pancreatic insufficiency, but you're not really showing those bowel symptoms, it may be on the back of other symptoms like the abdominal issues or the weight loss as well. So we may be looking into that for other reasons as well. So what exactly is pancreatic exocrine insufficiency? So essentially it's lack of digestive enzymes. So if we take, for example, if I sat down and had a cheese sandwich, when as soon as the smell and the sight of that cheese sandwich, starts my pancreas kicking in to release digestive enzymes. So as I eat my sandwich, it enters my stomach. There's some digestion that already happens in the stomach, and then it starts to enter into the small bowel. And at the top of the small bowel, as that food enters, these nutrients, so the carbohydrate from the bread, the protein from the cheese, and the fat from the cheese and the butter on my bread, all need breaking down to smaller particles. So as those nutrients enter the top of my small bowel, my pancreas starts spitting out these enzymes. And these enzymes then work on the carbohydrate, the fat, and the protein to break them down to smaller molecules. So as those nutrients pass further down my small bowel, then they're small enough to allow absorption, which then obviously enters the bloodstream, gets into the cells to be utilized as energy. Or if I'm overeating, then maybe be used as fat, or if I'm doing exercise and muscle. But what happens with pancreatic exocrine insufficiency is there's a lack of these digestive enzymes being produced, or no digestive enzymes if you've had total pancreas removed, total pancreatectomy. So in that case, we then need to use digestive enzymes taken in a capsule form, and there's a picture there as an example on the screen. These enzymes are from a porcine base, so they are pork based, and that's because their digestive enzymes are more similar to ours. So if you are concerned about that, then again, that's a conversation to have with your health team, but a health profession team. But unfortunately, there's not a alternative to the same degree. I know there are products you can get in the health food shop, but they're not the same dosing. The digestive enzymes need to be taken with food and taken with anything that contains fats, protein, or complex carbohydrate. So that also includes milky drinks as well. If you have fruit on its own, unless it's like an avocado, which is quite fatty, if you have fruit on its own, or something that like just sugar, such as wine gums, you do not need to take the enzymes, because that can be absorbed okay without the enzymes. But other things need to take the enzymes. They should be taken just before the first mouthful, and then you start eating, you have your milky drink. And they should be taken with not a hot drink, because a hot drink potentially denatures the enzymes. If you find that you're taking all your enzymes as you've been told to do at the beginning of your meals and snacks and milky drinks, but still we're not getting sufficient relief, then you could try splitting the dose. So have half of your dose at the beginning of the meal, half midway through. So we're sort of mimicking what normally physiologically happens in the body if you have, if the enzymes are being produced by the pancreas properly. Don't chew or crush the capsules. And if you have trouble swallowing the capsules, then again, we can talk that through. These are sort of the starting doses, and this is based on the units of lipase per capsule. They should, as I said, they should be taken with your meal, snacks, and any supplement drinks as well, if anyone's on nutritional supplements. The enzymes function best in a basic pH. So if you are, again, not finding sufficient relief for these ongoing symptoms, despite taking your enzymes correctly, you might be started on an antacid medication as well to help them work better. And if anyone's diabetic and you start digestive enzymes, it's important to note that because you're now absorbing better, which is a good thing, it may result in raised blood glucose levels because you're getting the most out of your food. So then it's a conversation to have with your diabetes team, because they may just need to look at your diabetes medication and titrate it up a bit. But it's because you're absorbing better, which is a good thing. Now, obviously, I have to mention the current constraint or issues with supply of these digestive enzyme products, which if anyone is on them, you'll be aware of that probably. And unfortunately, it's likely to be ongoing, and it's really not an ideal situation. It's pretty rubbish, actually. We've been told there is supply, but it's coming in starts and stops, and it's a bit annoying, or not great. There may be a need to swap between different products. So I mentioned a few different products out there. So there may be a need to swap between different products depending on what's available in production. For some patients, we may need to be having conversations about titrating dosing down a little bit to ensure that you've got enough stock to cover all your meals and snacks. Really, with advice of a dietitian, there may need to be some alterations of diet. So fiber does impact on how the digestive enzymes work. They work less with really high fiber diets. So if you're eating a lot of fiber in the diet, you may want to just take a little bit of a step back. It's not following a no fiber diet by any means, but things like maybe if you, for example, if your breakfast cereal tends to be all bran or bran flakes, maybe mixing in a bit of Rice Krispies or cornflakes into it just to reduce the fiber a little bit might help. But again, a dietitian can talk you through that. And if you're not losing weight, and but you are symptomatic, then again, with a dietitian, we may be looking at reducing the fat in the diet a little bit. And this is really because the current environment that we're in, again, it's not an ideal situation, but we may need to do that, but with a dietitian. And then we may be recommending changes to your nutritional supplements if anyone's on oral nutritional supplements. I've got some pictures there as examples. So we might be swapping you to fat-free products or products that are semi-digested, because then you don't need as much of the enzyme products. We just obviously make sure you match that with your nutritional needs. But obviously, if we are having to use these products sparingly, there's more of a risk of deficiencies in fat-soluble vitamins. So again, all the more reason to be making sure that we are testing and treating any deficiencies. So I'll talk about bile acid malabsorption. So risk factors for bile acid malabsorption are mainly if someone's had surgery to the stomach or the bowel, in particular the end of the small bowel or the terminal ileum, or they've had your gallbladder removed as well. Or there's disease that's impacting any of these areas to a degree that it's impacting on bile absorption. So bile acid malabsorption, basically, so what normally happens is, say, for example, when I have my breakfast in the morning, my liver produces bile. It's released in response to my meal, and particularly the fat of my meal. And then about 95% of that bile is reabsorbed at the end of my small bowel, the terminal ileum, and then stored in the gallbladder. When I eat again, the bile is re-released again. 95% is then again reabsorbed at the small bowel, the terminal ileum, the end of my small bowel, and then absorbed, stored in the gallbladder. So there's this bile acid recycling that happens throughout the 24 hours. But if someone's had surgery that's impacting on this bile acid recycling, or this disease that's impacting on it, then there may be bile acid malabsorption. And we can use a test called a CCAT scan, which involves 2 scans in the same week to test for bile acid malabsorption. And so bile acid malabsorption basically means that bile is not being reabsorbed at the end of the small bowel, but instead this large amount of unbound or unconjugated bile is passing through the large bowel, which can irritate the gut lining because it's acidic and irritating, but also it can draw water into the bowel because it's not sort of bound to anything. It's a large volume of bile passing through. So the main treatment for bile acid malabsorption is these bile acid sequestrant medications, which bind to the bile and stop them from irritating the gut lining. It is important to note that bile acid sequestrants can interfere in themselves with absorption of fat-soluble vitamins, and so a general 1-a-day vitamin and mineral supplement should be taken. So your bog standard A to Z, and again, I can talk through that a bit more in the Q&A section if anyone's got more questions. So that should include some calcium and vitamin D in it. And also bile acid sequestrants also interfere with how well other medications work. So other than your digestive enzymes, which could be taken together with the bile acid sequestrants, any other medication, they should be taken about 2 hours apart before and after your bile acid sequestrant, because the bile acid sequestrant can bind to other medications. So if you're on any like cholesterol tablets or sleeping tablets or anything like, they need to be taken separately. And then if there's insufficient improvement in symptoms, despite using the bile acid sequestrants, or if you don't tolerate them, then we may need to look at reducing your fat in the diet. But again, that really should be with the support of a dietitian, because we just don't want you to be becoming malnourished or deficient. And also talked a bit about small intestinal bacterial overgrowth when I had that chart around diarrhea. So this basically is where bacteria that normally reside in the large bowel migrate up to the small bowel, and that can cause symptoms of diarrhea, bloating, abdominal pain, having to open your bowels during the night, these fatty steatorrhea motions, nausea, flatulence, vomiting, can also result in weight loss and deficiencies, and particularly surgeries to the gut can increase risk of small intestinal bacterial overgrowth or long-term use of antacid medication. So again, we may be needing to test. So testing is done mainly through a breath test where we look at gas production. But it may also, or some centers use an aspirate. So they go in endoscopy, take an aspirate from the small bowel and test it for bacteria. It's treated with a course of antibiotics. And there's a school of thought that taking a good quality probiotic alongside with a 2-hour gap between your antibiotic and your probiotics, so the antibiotics don't just kill the probiotics, can reduce the risk of reoccurrence of the bacterial overgrowth, and then carrying on the probiotic for a little while after you've completed the course of antibiotics to sort of replenish that good bacteria in your gut. But if we can't get to the root cause of the small intestinal bacterial overgrowth, there is a high chance of reoccurrence. Especially if you had surgery, we can't obviously reverse that, then there's a high risk of reoccurrence. So we may need to be testing and retreating throughout your journey. So just some more general points on diarrhea. So it's an uncomfortable topic, but probably a lot of people on this call are really used to talking about their bowels. But discuss it with your doctor, dietitian, clinical nurse specialist. Discuss it with your team if you're suffering with diarrhea. There may be a place for reducing fiber intake or some other diet manipulation, but just again, would caution that should be done with a trained health professional overseeing, because we don't want you to be cutting too much out of the diet. Polyol sweeteners, so xylitol, sorbitol, maltitol, and isomaltol sweeteners that can be found like sugar-free chewing gum, sugar-free mint, sugar-free chocolates, some like sugar-free or diabetic biscuits, and they actually can cause diarrhea in themselves. So avoiding those and going for normal sugar-containing ones, but maybe a little bit less of if you're concerned about your sugar levels, is better if you're suffering with diarrhea. Keeping hydrated, because you're losing a lot of fluid with opening the bowels frequently, and medication may be needed to slow down how the transit in your bowels, like Imodium or loperamide, or some of the medications I talked about with the pancreatic exocrine insufficiencies, the enzymes or bile acid sequestrants. And then important to be considering any deficiencies in vitamin and mineral levels. And there may be a place for probiotic as well for some patients, so talking that through with the health professional as well. And then I just want to mention about constipation. So if anyone's suffering with constipation, it's important to consider the causes of the constipation. Is it a new symptom? What if there's anything that maybe have triggered the constipation? Consider medications. So obviously, if anyone's on some pain medications that can cause constipation, particularly your like opioid or morphine-based painkillers, but they may be obviously needed as part of your pain management. So we have to kind of find a workaround to support you with the constipation. But talk to your doctor, your clinical nurse specialist or dietitian. And also maybe just consider as well if you're on any anti-diarrheal medication. So if you were suffering with diarrhea before and you just ended up having loperamide on your regular prescription and you're still taking it, then obviously that would be a quick fix to sorting out constipation. But changes in your medication, just obviously talk to the prescriber. There may be some emotional causes to the constipation, so considering that, or like so stress, or anything, environmental factors. It's important not to ignore natural urges to open the bowels. So if you need to go, it's finding a toilet and going, because holding it in actually can exacerbate constipation. Exercise can help, because that's using muscles, and also just that sort of gravity and movement can also help sort of contractions and help the bowels to open. Ensuring regular meals, so you're getting regular intake, that can help. Increasing fiber, so more whole grains, fruits and vegetables, except in the context of bowel obstruction. So if anyone's at risk of bowel obstruction, then please obviously follow the advice that you've been given by a health professional, and do not increase your fiber intake. And if you were becoming constipated and you've been told you're at risk of bowel obstruction, then you need to get in touch with your team, or take yourself to A&E if that's part of your management plan, because it's a medical emergency. So that's the case of bowel obstructions. Increasing your fluid intake can help with constipation, to soften the motions, and consider toileting habits. So position on the toilet, using a stool to lift your knees up, so you're in a better position to open your bowels, and consider taking time on the toilet as well, and being in a comfortable environment. So those sorts of things can help. I think it's often so moving on a little bit, it's often difficult when one's getting a lot of advice from different places. And I mentioned about diabetes and being advised around potentially healthy eating if you've got diabetes, but then if you're losing weight. So it can be a bit of it can be difficult to balance all the different advice, but it's important then that we prioritize what the main issues are, and focus on those. And we might need to feed in a little bit of the other advice, but it's about making sure that we prioritize what the main goal is with yourself, the particular concerns. And where there is conflicting advice, really we should be getting support from a dietitian, or talk through with one of your team. Discuss any concerns and what matters to you with your managing team as well. So just in conclusion, I think I've probably talked a lot, so apologies if I went over, but consider the cause of symptoms. Ask to see a dietitian if you're concerned, and patients who have a diagnosis of insulinoma or bowel obstruction, really they should have dietetic input. So I would be asking for that in those situations. Avoid overly restricting your diet, because we then risk malnutrition and deficiencies. If concerned about deficiencies, then discuss with a health professional. Avoiding high-dose supplements unless it's under medical advice, because there's an actual diagnosed deficiency. And keeping as active as possible, and keeping well hydrated.